Our second speaker, Mr. Imran Masood, is a consultant ophthalmic surgeon with a particular interest in complex cataract surgery, glaucoma surgery, and the ocular manifestations of Marfan syndrome. Mr. Masood trained at Moorfields, and he is the director of the glaucoma service at the Birmingham and Midland Eye Centre and the Birmingham Institute of Glaucoma Research. He also holds the prestigious positions of Honorary Senior Clinical Lecturer and Honorary Consultant Ophthalmologist at the University of Birmingham. We were introduced to Mr. Masood by one of our supporters, Daniel. Daniel had struggled throughout his childhood to navigate everyday life, but after his intraocular lens implants, he now has a new clarity of vision and second sight, thanks to Mr. Masood. Welcome.
Thank you very much. Can you see my slides?
Yes, we can.
Okay. So thank you very much for asking me to speak. And what I'm going to talk about today is Marfan syndrome and the ocular manifestations. And I have a particular interest in the lens in Marfan syndrome. And what I will do is I will be sharing some surgical footage as to how we can deal with lens problems during the talk. So let's just look at the eye. So the eye is a fascinating structure, and that's why I'm an ophthalmologist. And you can see here that you've got the pupil, the iris, and then as we dig deep into the sort of structure of the eye, we look at what we call the lens. Okay, the lens is sitting here. Okay, and these ligaments are the zonules, and these ligaments have this protein called fibrillin. And this is what is damaged in Marfan syndrome, or is not normal, and that's why you get progressive loss of these zonules or damage to the zonules, which results in the lens dislocating. So here again, we look at the zonules. These are the critical structures, which again in Marfan syndrome become affected pathologically. And you can see that these ligaments are holding the lens in position again. And this is the reason why the lens starts to progressively dislocate from its normal position. Now, as you already know, you're very knowledgeable people about this condition. It's an autosomal dominant mutation in the fibrillin-1 gene, amongst others. And this was discovered in 1991. 800 or so mutations have been described, and more are being described all the time. And the thing about ocular manifestations, they're actually quite common. So lens issues arise in around 70% of patients. The other problem is retinal detachment. So the retina is the light sensitive layer at the back of the eye, and it can detach, can peel off like wallpaper, and that needs surgery as well. And then glaucoma can happen in Marfan syndrome, although the incidence is less clear. Some of these problems, the lens issue and the retina issue, can result in glaucoma as well. And a number of patients with Marfans are also myopic, or what we say very short-sighted. So when I look at a patient on our microscope, and a number of you will have been examined by an ophthalmologist or an optometrist on the microscope, this is what we see. So when you dilate the pupil, you get this beautiful red reflex, and this is a type of red reflex you would see sometimes in your photographs, and it's just a reflection of the light from the back of the eye, from the retina. And you can actually then see, so the lens is sitting nice and central here. This is a normal eye. Now, if you look at the eye of a patient with Marfan syndrome, you can see that the lens has moved across. It's almost like the sun setting, or the moon covering the sun, like an eclipse. And you can see here these little strands. These are the zonular fibers that are pathological. They're damaged and they're stretched, and so that's why the lens is moving across. Now, what impact does this lens dislocation have on the vision? Well, in some patients, it's none. And I've certainly seen patients with mild dislocation whose vision is absolutely fine. The symptoms that you get very much depend on the anatomy, the position of the lens, and the clarity of the lens. Because the other thing that we see is that patients whose lenses do start to dislocate, they do tend to form cataract a little bit earlier. So you might have a slightly dislocated lens, but you may also develop a cataract within that lens, and that may affect your vision as well. So in terms of treatment, we can use glasses, we can use contact lenses, and then sometimes we have to use surgical treatment. And the question is, why do we have to do surgery? Well, sometimes the edge of this dislocating lens ends up right in the center of your visual axis, right in the middle of your vision. And so then it makes it very difficult to correct with contact lenses or glasses. And as I said here, if you can't correct the vision with glasses, or the contact lenses are not tolerable because not everyone can put contact lenses in their eye. I mean, certainly I would struggle because I don't like anyone going anywhere near my eyes, even though I'm an ophthalmologist. And sometimes you can get fluctuation in your vision. So the lens is a little bit wobbly, and so it kind of moves around, and that affects your vision. And then the other more complicated problems can arise. So sometimes the lens, all the zonules basically ping off, and what happens is the whole lens moves into the front of the eye and can cause glaucoma or inflammation as well. Or, and as I said, cataract. So if you develop a cataract, obviously in a dislocated lens, you would definitely need to have surgery. Now, this is just a surgical footage. This is sort of the traditional way of dealing with dislocated lenses, and it's something that often patients are referred to a retinal surgeon, and what the retinal surgeon will do is they will do a vitrectomy, which is basically removing the jelly at the back of the eye, and then they will use this little vitrector. It's a tiny little mechanical sort of suction device. It'll basically break up and eat up the lens. And what happens with this approach is, A, you're going into the back of the eye, you're disturbing the vitreous, the jelly at the back of the eye. And the second thing is you're taking away the capsular bag. So you then have to have alternate strategies to fix a lens inside the eye to the wall of the eye. Now, and in my mind, this is a quite an invasive operation, particularly when you're doing it in very young people. So this is something I became interested in a number of years ago, is how can we rescue the capsular bag in Marfan syndrome, and how can we do this operation without touching the vitreous? So this is an example of a patient who's got Marfan syndrome, and you can see the lens is significantly dislocated. It's all the way across. And this is a video of how we did the surgery. This is a young patient, and I'll just talked through the surgery. If you're a little bit squeamish, then please look away or turn your screens off. But basically, we're making some incisions into the eye. This operation is done under general anesthesia, so the patient is asleep. I tend to do that in younger patients because these are not straightforward normal cataract operations, which take 10, 15 minutes. These can take about an hour and a half to do. But I think it's well worth investing this time because you can get a very good result and not subject the eye to as much trauma as in the slide I showed before. So what we're doing here is we're putting some jelly into the eye. Because the eye is full of fluid, this jelly is just there to kind of support the eye, stop the eye from collapsing when we're doing the operation. And now this is the sort of tricky bit. What we've got to do is we've got to open up and make a little hole in the lens capsule. And the reason we have to do this is because we have to aspirate the normal lens. We have to take it out of the capsule. And you can imagine the lens capsule and the lens, it's a bit like a Smartie. What we're trying to do here is what we're doing here right now is we're opening up the shell of the Smartie, if you like, and we're going to suck out all of the chocolate because that's what the lens, that's effectively what the lens is in this sort of analogy. And what we're doing here is just trying to get as good a view of the lens as we can when we make this opening. I'm just going to skip through a little bit of this because this is actually quite challenging and obviously takes a little bit of time. So a number of instruments being used to try and create a circular opening within the capsule of the lens. So going all the way around, and that's just, again, I'm just trying to make this nice circular opening in this capsule. And then we finally complete that. We've gone all the way around now. And you can see that now. You can see you can probably catch the edge of that there. And now what we're going to do is we're going to try and stabilize this capsule while we take the lens out. So there you can see the edge of the capsule there. And we've got a nice, this is the edge of the capsule. It's all the way around. It's nice circle. And now we're going to put these little hooks on. So these hooks are basically acting like artificial zonules. We're trying to support the lens while we remove it so that it doesn't drop into the back of the eye. So these are tiny little hooks we put on the edge of the capsule. And as you can see, we're gradually increasing the tension, trying to move that capsular bag back into its normal position. Now, because this is a very young patient, the lens is very, very soft, so you can actually remove it relatively easily with this little vacuum. This is like a little vacuum handpiece. We connect it to a rather large machine that we control with our foot pedal. And you can see there, I'm just using this to just suck out the lens. And as I said, it's a very soft lens, so bits of the lens are now being sucked out. And we'll just forward that a little bit, and you'll see at the end of all of that, once you've removed all of this lens, you end up with a nice, clear capsular bag. And the whole purpose of this is to conserve this capsular bag and without causing any more trauma. So the next thing to do is, and this is the really clever thing, this is called a capsule tension segment. So this, using this, we're effectively going to reconstruct the zonule apparatus that's missing here. Okay, so there's no zonules over here. And here's the little segment. We're going to put this into the eye, and the segment has a little hole there. And what we're going to do is we're going to use a little stitch to lasso that little hole, and then we're going to stitch this to the wall of the eye. So we're opening up the tissue of the surface of the eye so that we can access the wall of the eye, which is the white part we want to access here, because we're going to stitch this little segment using a suture to the wall of the eye. So let's just go forward a little bit more. And we're just passing a needle in. I'm just going to show you now the suture part. Here's the suture, and we're passing the suture through the little hole there, and there it goes. And then we grab it from the other side and pull it out, and you'll see that being pulled out there. I'm going into my little forceps, and I'm going to pull that out because we need that to lasso this little plastic segment. And let's just skip through that just to speed up things. That's the other loop. And then we're going to put this little segment into the capsule. Now watch what I do. As I ratchet the tension up on that, you'll see, and as I tie the stitch, that little plastic thing will pull the capsule across, and you can see that it's becoming more and more central now. And there you can see the edge of the opening that I made earlier. And the next thing really to do is to implant a lens inside this capsular bag. And you can see it's all nice and central now. And I'll just skip through this. There's the lens. It comes in as a foldable lens that we can inject through a 2 millimeter incision, and it opens up inside the eye. And we just get that into position. And there you go. You've got a nicely centered intraocular lens in a patient who had a very dislocated lens to begin with. And now the patient will be able to see a lot better. Now, I'm just going to go on to the next one. So this is a very interesting case of another patient where the whole lens, all the zonules and ligaments have gone, and the whole of the lens is now sitting in the front of the eye, effectively. So we can't save this capsular bag now because it's too late for that. But we've got other ways of dealing with this. So in patients with very dislocated lenses like this, what we do is we basically, again, make an incision. I'm going to, and then this is quite a nice sign. You can see the edge of the lens there. All of it is here. And what we're going to do here is we're going to put a little vacuum cleaner in and just suck all of this out. And I'll just show you that part. There we go. Okay, so this is a slightly different vacuum device. And we're just going to push that inside the lens capsule. And then we're literally just going to suck up all of this lens very, very efficiently. And you can see it's all disappearing into the little vacuum cleaner. Sorry. And let's just see where we are here. Okay, just show you, there it is. So that's the last remnants of that lens gone. And now we have no capsular bag, we have no support. So the next question is, how are we going to put a lens in an eye like this, which doesn't have any of these? So what we do is we use a technique which was developed by a surgeon in Japan many years ago. And what this does is it basically allows us to use a fairly standard lens. But what we do is I'll show you what we do. We put the lens inside the eye. Okay, there's the lens going in. Okay, and then we use these tiny, tiny needles. This is the center of the lens. These are the legs of the lens. Okay, so these legs normally sit inside the capsular bag. But in this case, there is no capsular bag. So what we do is we use these needles to actually exteriorize or bring these little legs out of the eye. Okay. So here's the first needle, and you can see that I'm passing the leg of the lens into the needle there. And it's really, like I say, it's really ingenious technique. And what we do then is as we gradually pass this in, the whole of the leg of the lens is inside the needle now. And then what we do is we do the same on the other side. So I'm just going to show you the other side. That's one side done. We do the same on the other side. There's the other needle, and we go into the eye again, and there we are, just feeding that little lens leg in. And I'll just go through this area here. And then what you do is as you pull these needles out, those legs come out following the needle, and you'll see the little legs coming out of the wall of the eye just there. What if you keep watching just there, you can see that legs come out. And then what we do is, again, a nice ingenious technique is to make a little ball out of that little leg, and that ball will then slot back into the wall of the eye, and the lens won't fall back into the eye because you've got that little sort of ball or mushroom that you've created that's holding the lens in position. You can see you feed that little sort of leg back into there, and that ball will hold the lens very, very securely. And the lens is nicely centered. And both these patients had an excellent sort of visual result. So that's the end of what I have to say. But the overall point I would make is that I think we've made a lot of advances in the way we manage dislocated lenses and Marfan syndrome over the last sort of 10, 15 years. There are, like I said, there are surgeons using other techniques as well, whereby you do a vitrectomy. And there's a little bit of debate sometimes about what the best technique is. But certainly in my practice, I found that these sort of minimally invasive techniques that I've shown you are extremely helpful at visual rehabilitation of patients. Thank you very much.
Thank you very much for concluding on that optimistic note and showing us the intricacy of the intraocular lens implants. The chat feed is filling, and Melissa has asked, what are the risks of losing all sight in the eye with this type of surgery?
Yeah, so it's a very, very good question. And obviously that's when we consent patients for surgery, that's the first thing we say, what's the risk of sight? Fortunately, the risk of sight loss with surgery now, eye surgery generally nowadays is pretty small. And I would say that the two things that cause sight loss in surgery generally are bleeding or infection. And I would say nowadays the risk of serious sight-threatening complications, less than 1%.
That's quite definitive, thank you. And Sarah has said, I had vitreoretinal surgery in 2016, removed lens in one eye and implant in the other in 2022. Contact lens correction is just as good as the implant. I'm waiting for more long-term data on the implant I had before deciding if I have the other eye done, because my vision is so good in my aphakic eye with the contact lens and glasses.
Yeah, I think contact lenses are great. I think they're a very good option, but unfortunately, not everyone tolerates them. And also, contact lenses in some patients who have very dry eyes, for example, again, those patients can't tolerate them. You know, I think the other issue is, of course, that there is a small risk long term with contact lenses of infection as well. And you have to remember to put them in. You have to take cases, so it's the convenience as well. So I think you're absolutely right. I think contact lenses are a fantastic way of managing aphakia. But like everything in life, that you know, having multiple options to address the multiple needs of varying patients, I think that's very important. But absolutely, I think contact lenses are great.
And Robin has asked, I understand that in Marfan patients, the eye tissue itself could be soft, and so that replacement lens legs could be at risk of pulling out.
Yeah. So I think that it depends on how you deal with the dislocated lens. So the first operation that I showed, which was using the segment and stitching that to the wall of the eye, that's actually quite a durable surgery. And I mean, I would say I've been doing it for about 10 years, and I've not had any patient that's come back with a dislocated lens in that scenario. Now, as regards the legs of the lens in the second scenario, can those legs pull out? I mean, by all means, the again, in my experience, not that common. A lot of this, I mean, a lot of this is surgeon dependent. Surgeon techniques do vary. Different surgeons, some people will use this technique that I've shown you with the legs pulled out the eye. Some people will use another lens called a Carlevale lens, which brings out a much bigger little segment of the lens and stitches that under. Other people use sticker lens onto the iris. So there's lots of different ways of putting a secondary lens in. I would say that there isn't good evidence. There haven't been many studies done comparing all of them. Like the ideal study is what we call a randomized trial, where you randomly assign people to two groups. That kind of study with secondary lenses hasn't been done, so we don't know which is necessarily the best. They all have their pros and cons. In my view, this particular technique that I use is the most minimally invasive, and certainly in my hands, the longevity is reasonably good. But I understand the point you make.
Amanda has said, I had a vitrectomy and lens implant in 2015. It failed within 2 weeks. Since then, I have had repeated problems, several bouts of CMO treated with steroid drops, but now have a decompensated cornea as a consequence of having now developed a cyst in my iris as a result of the surgery. I'm now facing two further operations, one to remove the cyst and implant another lens, and the second will be a corneal graft. Before the surgery, I had perfect vision in both eyes using contact lenses, but now I can barely see with the eye that was operated on. The initial surgery lasted over 2 hours as the lens was so cataractized. I mispronounced that, sorry.
Yeah.
Yes.
I mean, it's a tragic to hear about what's happened to you. Unfortunately, you know, it is a difficult one, and I think that um, sometimes you go down this road of having surgery, and then you wonder, well, it was all great beforehand. Why did I go down this road? I do feel for you. Unfortunately, complications do happen with eye surgery, and when you're in this situation, it's really difficult to kind of, sometimes, as I say to patients, you open up a can of worms, and so. I'm very clear. If a patient comes to me with aphakia, I am very clear that you could be opening up a can of worms here. And if you're happy and you're okay with your lenses, persevere. But I understand what you've been through. I think it's a difficult one, and I'm sorry for to hear what's happened to you. It's not nice.
Um, Sarah bemoans a lack of optician expertise, has worked at Moorfields, and she's also noticed that in support groups, people report complications after 5 and 10 years, which isn't acknowledged in the literature.
Yeah. No, I think that's correct. I think the problem with a lot of interventions in medicine generally is that most of the studies only last a few years. So if you look at other areas of medicine, 2, 3, 4, 5, 4 year studies, I think that is an issue. I think that again, when you look at longer term complications, I mean, even routine cataract operations, there are a number of. So if I go out to 10 years, even the bog standard cataract patients, some of them, their lenses dislocate, some of their lenses go cloudy. So we are always dealing with problems in the longer term. So I completely agree with you that we probably don't capture that data as well as we ought to, because that's important in terms of informing patients about the longevity. Because a lot of our patients, a lot of the ones that I operate on are teenagers or in their 20s. But the other issue is, of course, we haven't had some of these technologies around for that long, so that we can actually say that, for example, using this segment that I use, that segment's been around for probably about 10 or 15 years, and we don't have that length of experience with some of these techniques. But you're absolutely right, we do need long-term data on a lot of these things.
Um, Jaswinder has said that her son has Loeys-Dietz and he's had a few corrective surgeries for divergent and convergent squints, which have not been very successful. So his eyes are still very wobbly. In the last consultation, they said they may discharge him and he can come back if he has any issues. It was also suggested Botox to help with the squint, which another of the patients had. Advice, please. Is it worth having Botox, as it's not permanent and he will have to have them done regularly, especially it is not done under general anaesthetic, and he's needle phobic. He's 21 years, and now they want to discharge him.
Yeah, I mean, again, a very, very difficult scenario. I'm not, I mean, I'm hands up, I'm not an expert in squint. So, but I do know, yes, you can use Botox, and yes, Botox does have a limited lifespan. Sorry to hear that the operations have failed. I mean, if sometimes it's worth getting a second opinion from someone who's a an expert in squint, because there are in and you, I'm sure you guys know this, that in medicine there's people who do things, and then there's people who kind of subspecialize really in depth in some area. So there are certain ophthalmologists who will deal with squint but do it at such a high level that they get referrals from other squint surgeons for complicated squint problems. So it's well worth thinking about getting a second opinion from someone who is perhaps a super specialist within the area of squint to see whether anything else can be done. But I completely agree with you. Having Botox, ad infinitum is not really a solution.
I think I've reached the end of the line on the chat feed. Does anyone? Oh, a further message. Oh, thank you. Are there any further questions for Mr. Masood? No, nothing's emerged. Oh, Amanda has said I resisted having surgery for 10 years after I experienced total dislocation of both lenses, but was told by my surgeon I had no choice as the calcification of my lenses risked my eyesight. I still have the other dislocated lens in my left eye 10 years later, and it hasn't caused a problem. Is this likely to cause a problem in the future?
So it's a great question. In the very long term, I mean, I've certainly seen I think I've seen a couple of patients in my career who left the lenses who had dislocated lenses and kind of left it for years and years, like for 30 or 40 years. And eventually it does become cataractous. And it might actually be okay for a long, long time. On the odd occasion, the lens actually starts to leak. If it starts to leak, that can cause inflammation and high pressure in the eye. So there is a very small risk that if the lens becomes cataractous in the back of your eye and starts to leak, you could end up with pressure problems and inflammation. Now, it could always be removed at that stage. So it, but generally leaving a natural human lens in the back of the eye is absolutely fine. But so long as the capsule is not breached and the capsule is intact, which is the case in Marfan's and these conditions. So from my perspective, if you're using contact lenses and lenses in the back of the eye, that's absolutely fine. Obviously, you have to have your pressure checked and inflammation looked at from time to time, probably 6 months, 12 months. If you ever develop inflammation in the eye or pressure starts to go up, then that would potentially indicate that the lens might be leaking, in which case you would have to have it removed at that stage.
Thank you. Thank you. That's perfect. Okay, last chance saloon. No further questions for Mr. Masood. If not, thank you so much for sacrificing your Saturday morning.
Pleasure. Thank you very much.
Marty metaphor, which made everything so clear. Thank you
Take care. Bye.
very much. Thank you.